Hello guys, Dr. Mukul here, your orthopedic instructor here at Unacademy. So please just give me a thumbs up if the audio visual is okay. Alright, thank you for the lovely comment here, Jack. So guys, if you guys are in, please just give me a thumbs up so that I know that you guys are all comfortable with me and I can just begin up with this very important area. Discussing with you some commonly encountered controversies in orthopedics. Some questions that have come up many times, but people have been a little bit confused concerning the answers. So this is a special session dedicated to that particular area. So thank you for letting me know, Sachin. Okay, so we begin. The commonest nerve injured in the fracture shown in this X-ray. Now this is one of the repeat questions from the previous AIMS paper, and a very nice question, I would say. So this was a pretty close call, a very close call. So you had to pick up the answer as to which is the commonest nerve involved looking at this X-ray. The difficult point here was that you had to read the X-rays to come to the answer. So okay, so there's a very unanimous decision. Choice C is the answer. Most of the people think it is anterior interosseous nerve, but there's a answer. There's a preference for a radial nerve also, I can see among some people. So that's exactly what the confusion was. That would AIN be the better option or would radial nerve be the better option? So I would go here with the radial nerve as the answer. Although that's not the answer of the house. But let me be very clear. See, what you have in front of you is the Holstein-Lewis fracture. It's the Holstein-Lewis fracture, to be specific, guys. Now, Holstein-Lewis fracture tends to be a fracture of the shaft humerus. And this fracture classically involves the junctional area, the junction of the upper 2/3 of humerus and the lower 1/3 of the humerus. So you can pretty much see this is the upper 2/3, this is the lower 1/3. That's where the fracture is. Now in Holstein-Lewis, almost in like 90% cases, you are bound to find a radial nerve palsy. And that's why perhaps the answer here is the radial nerve palsy. Now there were so many people who were banking up for the answer to be anterior interosseous nerve. So can I just request them to let me know like what was in their mind, because it's like so many people said that the answer is anterior interosseous nerve. So I think there must be something like some kind of a diagnosis in your mind that you were thinking of like anterior interosseous nerve as the answer. So Shrikant, Karthik, you guys all were thinking that the answer is AIN. So perhaps can I just ask you guys, like, what was the picture in your mind concerning this fracture that you thought that AIN would be the answer? Please mind you, there is no AIN in the arm. Still you were thinking that the answer is AIN, anterior interosseous nerve. So can you guys share your thoughts with me, like what made you prompt to me that the answer is AIN? Yes, Shrikant, Karthik, can you guys just share your opinion with me? You were thinking supracondylar. Perfect enough, yeah. That's a close call actually, guys. See, if it fractures supracondylar humerus, AIN would be the nerve that will be involved. But I would say that this is far away from being fracture supracondylar humerus. And I would give you my reason why. See, a fracture supracondylar humerus, you would find the fracture line traveling through the olecranon fossa. I hope you can all see this fossa here. Pretty much visible to you. Now, had the fracture line been traveling through this fossa like this, this is where you would have said that this is fracture supracondylar humerus. So clear, dear? Clear, dear? So clear with that? So if you find the fracture line traveling through this area, That is where you say this is fracture supracondylar humerus, and then you say that is AIN. The fossa is totally intact here, so this is Horst-Lewis. So the answer here would become radial nerve palsy. Otherwise, you need guts to say AIN here. Okay, this is a fracture a little too high up. AIN is given in the forearm. You don't have AIN in the arm, so this fracture can no way injure the AIN. Clear enough, guys? Now, have you ever wondered which is the second commonest nerve that is injured in this fracture supracondylar humerus? So I hope you can pick it up now. That this is a fracture almost through that olecranon fossa. So here you will keep it as like the diagnosis as like fracture supracondylar humerus. Okay. So have you ever wondered like which is the second commonest nerve involved? Okay. No, AIN is the most common one. So AIN is the most common nerve involved. So this goes out. The question says second most common nerve involved. Okay, ulnar nerve. No, I won't say ulnar nerve. Generally in operated cases, ulnar nerve can be involved, but not in fresh fractures. Supracondylar humerus, rare. Median nerve. No, I won't even say median nerve. No, I think this is the best answer. Radial nerve. See, you will understand this answer if you just understand how the hell is AIN involved in this fracture. See, I have been repeatedly pointing out to you that there is no anterior interosseous nerve in the arm. And this is a fracture in the arm. Humerus. Supracondylar humerus. So how is AIN getting involved? Once you would understand that up, you would understand the second commonest nerve involved is going to be radial nerve. And you will understand that median nerve would hardly be involved. Had median nerve been involved, AIN would not have been involved. I will just show you how. See, this is fracture supracondylar humerus through that olecranon fossa. And this distal fragment tends to have the attachment of this big muscle, triceps. So the triceps generally pulls the distal fragment back. So this distal fragment has been pulled back by this muscle, triceps. Now in the front, you have this median nerve here. This is the median nerve. So obviously, as this proximal fragment is going to go in front, it is going to kink this median nerve. Now please, this is the median nerve here that I've shown in front of you. Clear enough, guys? Let me just clear this up. It is extra thick here. So I hope now you can pick up. This is that median nerve going in front of the arm in that cubital fossa. Now in supracondylar humerus, you will have a fracture through this area. And then this proximal fragment will be kinking this nerve. Now median nerve is a very flexible nerve. There is no tethering anywhere. Now median nerve, somewhere around this area, gives a branch that travels under this muscle that I've shown in front of you and then goes in the forearm. This muscle I've shown to you is this muscle pronator teres. Now AIN is basically traveling under this muscle pronator teres. Now AIN is beginning here and then it is tethered along the course under the muscle. So there is no flexibility in AIN. So this nerve AIN is relatively much of a fixed nerve. So when this kinking pulls the median nerve, the AIN is also pulled, and AIN cannot bear the stretch because it is a very fixed kind of a nerve. So clear, guys, how AIN is involved? Median nerve will not be involved because it can bear the kink, because it is totally loose. So even if it will be kink, it will be displaced. It's not going to be broken, stretched or paralyzed. Clear, guys? Now please, this is the lateral epicondyle, and going right in the front is the radial nerve. Now if at all there will be a fracture here through the fossa, and this little fragment will go in front, like you can see over here, this fragment can also displace the radial nerve a little bit. Now just in front of the lateral epicondyle, this radial nerve gives a PIN branch, and the nerve itself also travels into the muscles. So this radial nerve is also a bit fixed. So too much of displacement can also injure the radial nerve. Clear with it? So are you guys now thoroughly clear with the nerve involvement in fracture supracondylar humerus? Clear with it? Okay. Aman, I have already mailed you up your query, the treatment of CTV, but never mind, since you have asked it here, I will clear it in the lecture also. I'll clear it in the lecture also. In a live lecture, you never go home without clearing your doubts. That's the whole idea of having a lecture live. Okay guys, so clear with this part? Can I have the thumbs up in case you guys are like thoroughly clear with this part? Okay. Alright, so I suppose things are pretty much clear till here. ये चीज़ समझ में आ गई है. Okay, so I'll just go ahead and share this very nice picture with you. So there's a plaster shown in front of you. So this gentleman who's in front of you, he's carrying some plaster. Now this is a very indirect kind of a question. Maybe a kind of a question where the examiner wants to check whether you've attended your clinics or not. So he's shown you a picture and he's asked you that looking at this picture, please give me the diagnosis. And perhaps an orthopedic surgeon should be able to do that. So that's why your skill is being tested. So perhaps what I can see that it's a very monotonous decision from you guys. You think it's a scaphoid fracture. Perhaps you think it's a scaphoid fracture because you think this gentleman can be given a glass to hold and this is a glass holding cast. No. I'll just take away the glass from him. No. See, first of all, this is not a Colles fracture because here you have a handshaking cast and this is certainly not a handshaking cast. It's not even the scaphoid fracture because it's not a glass holding cast. I'll tell you why. Look at the tip of the thumb. Look at the tip of the thumb. You will find that this tip of the thumb is incorporated in the plaster. Thumb free नहीं है. If you want to hold a glass, thumb has to be free. Otherwise, you can't catch a glass. If the thumb is fixed, you can't hold a glass. You need the movement in the thumb to hold a glass. So guys, you were mistaking it up. This is not this glass holding cast. This is a thumb spica cast. And this is given in case of Bennett's fracture. So that's the answer. Clear guys? So please be a little careful with it. See, this is scaphoid cast. Now this is exactly what you call as that glass holding position. See, this gentleman can be given a glass and see this tip of the thumb free. So interphalangeal joint of the thumb will be free. If at all it's a scaphoid cast. Well, let me tell you, if you are applying plasters, then we follow rule of 2. Rule of 2 means we extend the plaster to one joint above and one joint below the fracture. That's it. Like I'll just give you an example. See, this is that hand shaking cast. And you very well know that this hand shaking cast is given in cases of Colles fracture. Now Colles fracture you will have at the distal end of the radius. So radius में fracture है. So the wrist is immobilized. But can you see the whole thumb free? Because from the radius we have gone distal to one joint wrist. So why involve the thumb? Now in scaphoid the wrist has a fracture. So we have immobilized the carpo-metacarpal joint of the thumb. एक joint ऊपर चले गए हैं. Why immobilize the tip? Bennett fracture, the metacarpal gets involved. This Bennett fracture, metacarpal gets involved. So when the metacarpal is involved, we have to obviously go and involve the interphalangeal joint. So are you guys clear with this identification part here? And are you guys clear with the rule of 2? So plasters जब भी हम लगाते हैं ना, we try to mobilize the proximal joint and the distal joint, taking the fracture part as a reference. Clear enough guys? Perfect enough? So perfect. Wonderful. wonderful, wonderful, wonderful. Okay. Now this is nowhere controversy. It's a very easy one. Because I must not give you all the controversial questions. Otherwise, you answer everything wrong and then you think the teacher is too frustrated. That's not the case. So that's an easy one for you. Easy one for you. Because somewhere down the line, I also want that you guys should be scoring some marks. So there's a fracture here in the tibia. A spiral fracture involving the lower tibia. Fine. Now what's classical about this fracture? Look at the fibula. Absolutely intact. मतलब टिबिया में तो फ्रैक्चर है पर फिबुला बिल्कुल इंटैक्ट है. No, this kind of an injury can only happen in children. So it's a green stick fracture. Okay, Karthik, Avinash, Palak, Mustafa, you all think it's a green stick fracture. Well, let me tell you guys, this is actually a toddler's fracture. That's the answer. Although these terms can be very, very overlapping at times, but this is a toddler's fracture. But yes, I know most of the times the commonest confusion that comes to that this is a green stick fracture. So it becomes my duty even to tell you as to what is exactly a green stick. See, look at this bone radius. This is ulna, this is radius. Now what you would find here with this bone, that one cortex of radius is broken. Can you see this cortex is broken? But if you're going to have a look at the other cortex, that's going to be intact. ये देखो, दूसरा cortex बिल्कुल intact है. Then please, ulna is a straight bone, and just like the ulna, radius is also a straight bone. But here you can see some curve in the radius, bending in the radius. So this particular area you can also see bending of the bone. So this is where you call a fracture as green stick. सिर्फ एक cortex टूटता है, दूसरा cortex intact होता है, bending दिखती है bone में. Here hardly any bending. Both cortices gone. See, both cortices gone. Not green stick. So I hope you guys will be able to pick up exactly as to what is the green stick fracture. And can anyone help me out with this question? Like, what is the appropriate treatment? Okay, why was D thought of? Well, dear Avasti, I think because many people don't exactly know the definition of green stick. I think that's why they make this mistake. They generally think that children are having fractures, so that's going to be green stick. That's not so. Children tend to have plenty of fracture patterns. Okay, most of the people think that a plaster should be applied in situ. No. This is the ideal management that is described for a green stick fracture. You're supposed to break the other cortex, then make this bone go straight, obliterate the bending, and then apply a plaster. Clear, guys? So that's how you actually treat a green stick. And yes, Sambhav, another fracture pattern you may have in children is the torus fracture. And what you tend to find in torus fracture, buckling of a single cortex of bone. So I hope you will be able to pick up यहाँ पे कि बोन का एक कॉर्टेक्स ना डिप्रेस हो गया है. Cortex of the bone is pressed inside. So this is where we say that this is a torus fracture. So this is again a special fracture pattern you find in children. Okay, so this is another special fracture pattern you find in children. Okay, we can't put it as tibia only fracture. There is no such term described in the literature as tibia only fracture. Sambhav, there are some specific terms that are mentioned in the books and in the literature. So if you will read this in the book, this fracture will be labeled as a toddler's fracture because you tend to find it in the toddlers. So I hope you guys are a little bit clear also concerning this part, the fractures you find in children. Okay, समझ में आ गया है शायद. I think that's pretty much clear to you guys. All right. Now this is another particular gray zone where people are a little bit confused always कि painless limb कब बोलना है, painful limb कब बोलना है. Okay. Now if we are talking of conditions that can produce a painful limb, the condition must fulfill either of the two criteria. Either there should have been some kind of a trauma, or there should be some event of infection, some inflammation. Like I'll give you some of the examples here. Septic arthritis, infection. Then there is a disorder called transient synovitis. Because of some non-specific reason, some synovitis happens in the hip. Inflammation, pain. Trauma, it could be simply an accident or something, or it could also be this condition, slipped capital femoral epiphysis. I think you're familiar with this disorder also. Because of the body weight, the growth plate of the neck of femur is ruptured. Slipped capital femoral epiphysis. So these are the scenarios, where you have to think about a painful limp, because there is generally some kind of a trauma or infection involved. Now both these conditions, no trauma involved, and then let me tell you, no infection either involved. So this is the answer, that both of these are causes of a painless limp. I think you already know what is congenital dislocation of hip and what is Perthes disease. See, Perthes disease is an idiopathic condition. So there is no infection, no trauma. But what you have here is avascular necrosis that will be involving the femoral head. And it will be spanning this age group 4 to 10 years. So that's exactly where you call that this is Perthes disease. Okay. Sometimes the examiner asks you about the X-ray signs in Perthes disease. So this flat head looking like a mushroom. Some people simply say a mushroom shaped head is one of the thing. Otherwise, this gauge sign is also a very popular thing. So what you have over here is a triangular lytic area, blackish area in the lateral femoral neck. So this is like also a very useful sign. And then another is the sagging rope sign. So here you tend to find a sclerotic. Sclerotic means whitish line along the medial femoral neck. So these are some of the X-ray signs of Perthes disease that you should be able to identify up. Okay, so do have a look at them. Okay, but I hope you got my message that Perthes disease is idiopathic, no trauma, nothing at all. Okay, it's just an idiopathic AVN. Okay, some people say the reason behind Perthes, what you have over here, this is the profunda femoris artery. This forms an arterial ring of the circumflex vessels encircling the head. Branches from this ring go up to supply the head. So this is one blood supply to the femoral head. Attached on the head here, you have a ligamentum teres. Now inside this ligamentum teres also you have branches of obturator artery that are supplying the head. Okay. Now guys, profunda femoris would be the dominant system after the age of 10 years. Obturator is the dominant system in younger age, 4 years. So perhaps 4 to 10 years is a bridge zone where the growth plate is fusing. So this profunda is penetrating, obturator is receding. So sometimes this development is a problem. So a phase comes, a small phase, maybe a month or two, where the vascularity is a problem and AVN happens to the femoral head. So that is what is happening in Perthes disease. So no trauma, nothing at all. Why pain? Clear? Sagging rope sign is this whitish line that you're seeing in the medial femoral neck. This is because of bone remodeling. So Perthes disease is also developmental, and developmental dysplasia of the hip is definitely developmental. Congenital dislocation of the hip, it's best called as developmental dysplasia of the hip, because what you have over here is the abnormal hip. Abnormal hip means you have a flat type of an acetabulum, and you tend to have a small sized femoral head. I hope you can pick up both the findings very nicely here in this X-ray. Look at this femoral head, so small in size, and see this acetabulum curved, see this acetabulum flat. So here also you can see no trauma. Clear? So painless limp. I think you're already familiar with these braces, splints we use in DDH or congenital dislocation of hip. They are very very popular MCQs. Please have a good look at these splints. बहुत बारी MCQs में आ चुके हैं. Clear enough? So palak, I have just explained to you the most logical scenario behind Perthes. Some people say that an element of infection could be there that could initiate the disruption of this balance, but that is so temporary. So if you talk of limp in Perthes, it could be painless, it could be painful for a brief time, but by and large during the maximum course of the disease, it's a painless limp. So classically speaking, limp in Perthes is taken as painless. That rare time where infection could be the inciting event, the limp could be painful. Clear enough with your query, Palak? Clear enough with your query? And guys, I don't think this condition needs a spot diagnosis. CTEV. I had to include it, and because this has been troubling Aman also. So Aman, your question is here. So what you tend to find in CTV, that the ankle joint goes into equinus. The subtalar joint gets fixed in the position of varus. What you tend to find at the midfoot in these people is the exaggerated medial longitudinal arch. That's called cavus. And concerning the metatarsals, you find that they are pointing medially. So basically they are adducted. So look at this foot. The heel is in the air because there is equinus. This is the rear view. पीछे से देख रहे हैं. So see the heel twisted medially because there is varus. Look at this exaggerated medial longitudinal arch, जिसे मैं cavus कह रहा हूँ. And just see these metatarsals adducted, अंदर को point कर रही हैं. So when you have these 4 deformities in the foot, that's where you label the diagnosis as CTV: congenital, talipes, equinus, varus. Equinus, varus. क्योंकि deformities का part है. Clear enough, guys? Cavus means exaggerated medial longitudinal arch. Here. Now in CTV, this question was asked once, that which of the following are causes of primary CTV and which is not. So primary CTV is the congenital variety of CTV when this deformity is present since birth. There is another variety called secondary CTV. But what you find over here, that the CTV will be developing after birth. अब इन कंडीशंस में से जो आफ्टर बर्थ होता है वो तो पोलियो है. सो पोलियो विल लीड टू सेकेंडरी सीटीवी. प्राइमरी, प्राइमरी, प्राइमरी. So these are all causes of a CTV present since birth. Spina bifida, arthrogryposis, idiopathic. Clear? Polio happens after birth. So that will be a cause of secondary CTV. And I think this is an easy one for you. Now the difficult part is the treatment in CTV. Different books give different treatment because the treatment goes by the age. But that age is not a strict criteria. Actually the treatment in CTV is more by the clinical acumen, how stiff the foot is. And of course, what is the age? And what is the growth pattern in the foot? See, not everyone grows at the same age. Someone gains height at 12 years age, someone gains at 16-18 years of age. तो actually बहुत complicated वैसे treatment decide होती है. Clinical acumen is an important part. But to an undergraduate, the treatment has to be simplified. So books simplify it in their own way, trying to just follow the age. So let me tell you, 0 to 7 days after the birth, we just keep the child under observation. The skin of the child is too fragile to do anything. From 7 days onwards, almost till 1 year, we go with serial plasters. I think you guys are pretty much clear that this is called Ponseti casting. Clear, Aman? Now, 1 year is the walking age. Okay? So, after a year, child starts walking. The goal is that surgery, if needed, should be over. Okay? Prior to walking age. क्योंकि बच्चे को टेढ़े पैर के साथ चलाओगे तो 10 तरह की और कॉम्प्लिकेशंस होगी, डिफॉर्मिटी और ज़्यादा आगे बढ़ेगी, और ज़्यादा ख़राब होगी. सो द गोल इज़ दैट इफ़ टिल 1 year इट्स नॉट बीन करेक्टेड बाई प्लास्टर्स, तो सर्जरी कर दो. Now suppose we are going ahead with surgery. How to choose grossly the surgery? Between the age of 1 to say 4 or 5 years, we go with this surgery, posterior-medial soft tissue release. The problem in CTV is that the posterior-medial soft tissues of the foot are tight. So we cut those tight structures to straighten the foot. Clear? But let me tell you, here also try casting first. If it was never tried, एक्चुअली ये रूल होता है, क्योंकि कास्टिंग से एटलीस्ट डिफॉर्मिटीज कम हो जाती हैं, सर्जरी का सक्सेस रेट ज़्यादा हो जाता है. क्लियर? सो दैट इज एग्जैक्टली द फंडा वी फॉलो. Once this age of like 4-5 years is reached, say till the age of almost like 12 to 14 years, here we go with bony osteotomies. तो अब हमें बोन को काटना पड़ता है, क्योंकि खाली सॉफ्ट टिश्यू से अब डिफॉर्मिटी करेक्ट नहीं हो सकती, रिजिड हो गई है. नाउ हियर इन अर्ली एज से 4 to 8 years, we go with procedures like Dilvinivans, because these are the procedures that depend upon growth of foot for correction. तो ग्रोथ फुट की पेंडिंग होनी चाहिए, सो अर्लियर एज में करेंगे ये वाली सर्जरीज. बियॉन्ड 8 years नॉट मच ग्रोथ इज लेफ्ट, सो वी जनरली गो विद वेज रिसेक्शंस. काट के पैर को सीधा कर देते हैं, पूरी बोन रिसेक्ट कर देते हैं, या यहाँ जैसे क्यूबॉइड न्यूक्लिएशन, क्यूबॉइड निकाल देते हैं टू करेक्ट द शेप ऑफ द फुट. दीज काइंड ऑफ सर्जरीज, सो बोन रिमूविंग सर्जरीज. ओके, रिसेक्शंस. Now somewhere around the age of 12 to 14 years, the foot becomes so rigid that here you are left with just one lethal option, that's called triple arthrodesis. Now triple arthrodesis is only done once the growth of the foot is complete. That takes around 10-12 years. The minimum age for triple arthrodesis is 10 years. But by 14 years, almost in everyone, the growth is complete. So actually, this is a wide zone. So you can take the average as maybe 10-12 years, 14 years. So clear with the message, dear Aman? So Aman, have you now understood that, actually, it's a complicated way. We side by side look at the stiffness level of the foot also. Like, we find the foot is too stiff. We don't waste much time with plasters. We quickly jump to PMSTR, even in a 6-month-old kid. Actually, there is a scoring in CTV we use that's called Pirani scoring, that tells us how stiff the foot is. So when the score is towards the higher side, there is a greater tendency for us to jump to surgical options earlier. Okay, and then let me be very clear regarding these bony surgeries. Yet there are so many bony surgeries. And the bony surgeries cannot be generalized, because at this age some other option would already be tried. So you don't have all the deformities in the foot. Some people may just have varus, some people may have just equinus. So depending upon those deformities also we decide like what will be the ideal surgery. So this much part is little too complex for you, but on a general scale, first 1 year this plasters, from 1 to say 4-5 years soft tissue surgeries, from 4-5 years to 10-12 years at least bony surgeries, and from 10-12 years onwards triple arthrodesis. So are you guys clear with this part also? How do you treat CT? So can I have the thumbs up, final one? यहाँ तक सब समझ में आ गया. Okay, Aman, especially from you, can we have the thumbs up? Aman, from you, can we just have the thumbs up? Like, समझ आ गया, because Aman had specifically mailed me and he was telling me that this is a very confusing part to him, because he watches so many videos on YouTube and different videos tend to confuse him. Okay, and then let me tell you guys, whenever we go for any damn bony surgery, a soft tissue release is always a part of it. मतलब पहले PMSTR होगा ही होगा, फिर जाके बोन को काटेंगे. हमने खाली बोन काट दी, टिश्यू काटा नहीं, deformity won't be corrected. So actually this is a very complex part. Getting it? But I've given you a simplified type of a table that will work for most scenarios. Clear enough, guys? perfect enough. So these are the splints we use for maintenance of correction in CTV. So once you correct CTV by any method, you're supposed to maintain the correction for maybe another 2-3 years. And for this we use the Dennis Brown splint. Very popular splint, has been in the MCQs a number of times. So do have a good look at Dennis Brown splint. So that's all from my side. You want to enjoy more classes from my side, guys, I'm sorry you'll have to go with the plus subscription, because I'm given just a limited time over here for the YouTube sessions. The subscription amount very economical. You can just check it up on the Unacademy website or app, and you'll get to know that it's nothing, barely marginal. This offer is there, 1 month extension you can have, okay, if you subscribe timely and use the code I'll just share with you. So what you can assess, you can assess all the batches that are already there, but I would specifically like to tell you, in case you're preparing for that NEET 2023, this is a very good batch that is coming up for you. It's going to sharpen up your skills, guys, and please make sure that you don't miss the very good question bank we have with us at Unacademy. Excellent question bank, excellent explanations, the perfect plan to prepare you up finally for the exam. And please not forget to compete in the live tests going on Unacademy. A lot of prizes to be won. Just check up the app and that'll be it. So guys, in case you like the lecture, you wish to subscribe, this is my referral code. So thank you from my side. Hope you enjoyed the session. So any queries before I just wind up and say goodbye to you? Any queries? So just in case you have queries once the class is over, this is a Telegram group I run, to which you can connect yourself to t.me Dr. Mukul Ortho. तो इस पे कनेक्ट कर सकते हो. You can ask me a query later also, but any query for now, in case you guys want me to answer, अभी कोई query है तो please feel free to ask me. Alright, so I suppose most of your queries are done. Okay, no more queries, but yeah, any queries you have, even once the class is over, this Telegram group you can join and you can ask me, and of course you'll be intimated about coming up more such sessions like this in case you are connected to this Telegram group. So hope you guys enjoyed the session. Bye bye for now, good night, keep preparing, wish you all the best, see you again.